Okay. So today we will discuss about mammography. So we know that breast cancer is the major cause of high mortality rate among females world over, and mammography is an imaging technique useful for determining the presence of carcinoma or precarcinoma conditions like masses, clusters of microcalcification of the order of 0.1 mm also, and distortion of structure in breast tissue. Physical density difference between normal tissue and affected tissue is marginal, but variation is significant in their atomic number values. So that is what is helping us to get out the information out of the mammography images. And radiological differentiation of normal tissue and affected tissue is therefore based on their photoelectric attenuation properties. So this is mass attenuation coefficients for different tissues as a function of photon energy. So on the x-axis we have photon energy, and on the y-axis we have mass attenuation coefficient, which is centimeter square per gram. So you can see that different how the mass attenuation coefficient varies for different tissues. So fat, the variation is steep at for low photon energies, but as the energy increases, the variation is not much. So that is why we need to use low photon energies for mammography, because we have to differentiate between soft tissue and soft tissue. And that is why we use a separate independent x-ray machine for mammography. So you can see all everything, the variation is very steep, it is falling down too much. With the mass attenuation coefficient, difference is big between low energies compared to the high energies. Like you can see that if it is at say 10 keV and 15 keV, the difference is big. For fat, if we take, it's here like 10 raised to 0.1 probably, and then if we take 20, then it is 10 raised to 0.7 probably. So there is huge difference when the at the lower energies. But as the energy increases, you can see at 100 kV and 110, 120, 130, 150, there is no difference at all, even among fat, muscle, bone. And that is where contrast also comes into play. Like you can see when for the iodine, the difference is little bit more pronounced at higher energies also. And type of tissue in breast, we have glandular tissue, fibrous tissue, fatty tissue, and there could be cysts. So we all of which have separate different appearance in the anatomy as well as for the radiographical mammography image. So here you can see mammography images of normal versus cancerous. So this is the image of a cancerous breast, where this is the normal image. So you can see that here the normal distribution of intensity variations are there. Here there is a pronounced difference in some tissue with respect to the rest of the tissue. For the mammography equipment, what all we need to consider and what all are our requirements. So we need high spatial resolution, because we need to identify even very small lesions. So that for that purpose we need very small focal spot, so that we will get very intense radiation output. And soft tissue imaging, low kV imaging technique, because we have to differentiate between soft tissue and soft tissue, and we don't need to penetrate any high density bones or things like that. So we can use low kV imaging technique. And here again we have a concern about the radiation protection also. The lung dose, heart dose, all these things are a concern. So further, to reduce the lung doses further or to minimize it as low as possible, so we are utilizing the lower kV, which is sufficient enough to image between soft tissue. And high contrast, again low kV will give us the high contrast images. Radio sensitivity of breast tissue is a concern again. So we have to give lesser patient dose because we are imaging breast tissue. Breast tissue is radio sensitive. So as per the new ICRU report, breast tissue is one of the most sensitive tissue in the body. So we have to ensure that we are giving lesser radiation dose possible. At the same time, we are getting a useful image. And optimal X-ray energy, ideally monoenergetic beam of energy between 15 to 25 keV or a spectrum with average energy of this order and with lesser, softer and higher energy components to reduce patient dose and to improve image contrast. So here are some elements that can provide characteristic X-rays in the useful energy range suitable for mammography. So here you can see the energy, like we have seen 15 to 25 energy range. So we have all these elements for which they have the K characteristic energies in that energy range. So we can see molybdenum, the atomic number 42 and KH energy is 19.97. So we have two K alpha 1 and K beta 1 transitions taking place. So which have 17.44 keV and 19.73 keV respectively. Hold on a minute. And we have ruthenium with atomic number 44 with K edge energy of 22.09 keV, and this has again has K alpha 1 and K beta 1. The energies are 19.25 and 21.80 respectively. Similarly, rhodium, which is again one of the most commonly used combination, which has atomic number 45. K edge is 23.19 and K alpha 1 and K beta 1 are 20.19 and 22.87 respectively. So we have palladium, silver, cadmium, these elements also whose atomic numbers are 46, 47, 48, which also falls into the same K edge values. So these also could be utilized for the purpose of soft tissue imaging. So this is a picture of the optimal energy for mammography is achieved by the use of specific X-ray target and beam shaping filters. So we can utilize filters also, like we have seen, like we should not have very low energies and we should not have higher energies also. We should have the energies which is in the desired range only. So this could be achieved by having a specific target combined with a filter. So here you can see the filtration properties of molybdenum and rhodium. So the rhodium is the dark line and molybdenum is the dotted line. So here you can see the K edge for both. For molybdenum it is 19 keV and for and here we have a 30 keV spectrum of tungsten target. So here you can see the photon per millimeter square. Like it's the counts which we are getting into 10 raised to 6 photons per millimeter square. So 30 kVp with tungsten target unfiltered spectrum will look like this. It has 8 to 12 kVp characteristic X-rays, L characteristic X-rays. there. So you know that from L to K, the transition, the characteristics energy will be more. And 30 kVp tungsten with rhodium filter is on the right side. So you can see that when the so two different filters are utilized, 0.025 mm and 0.050 mm filters. So you can see correspondingly the photon fluence is cut down. So here you can see the low energy photons also cut down, and the intensity of energies in between increased. So that means the average energy of the beam increased, and the higher energy component is also brought down. So here you can see the 0.050 mm filtration more effectively cuts the average energy. So you can see that all these, like even the intensity is also cutting down significantly by increasing the filter by 0.25. So this is again 30 kV X-ray spectrum of molybdenum target. So here we can see the unfiltered with 0.03 mm molybdenum filter, 0.025 mm rhodium. For the K alpha 1 17 kV and K beta 1 20 kV. So here you can see again unfiltered has high intensity in the higher intensity in the lower energy range 5 to 10, that is almost completely cut off with the filters. So this is what actually, this will not contribute to the image quality. This will actually hamper the image quality, as well as it will add to the radiation dose to the patient. So that we are completely cutting it off using the filters. And you can see that the 10 to 15 kV energies are also much lesser. They are also a good amount of that is also getting cut off. So what we need is like 15 to 25 kV. So we can see that 15 to 20 kV peak beach may we are getting the peak. The maximum intensity of the beam is falling between somewhere around 17. So you can see that. So the filter is also such that it filters off this part as well as the high energy part. Here also you can see that the high energy part is also like 25 to 30. The whole spectrum is cut off. And we can see that 22, 23, there also the intensity is reduced significantly, but there is a slight, small amount of photon beams with higher, more than 20 kV energy. But the number of photons with more than 20 kV energy is also brought down significantly. So we have a consistently higher intensity beam of between 17 to 17 kV over here using this molybdenum filters, molybdenum or rhodium filters. You can see the difference between 0.03 mm molybdenum, which is the dotted line, and 0.025 mm rhodium, which is the darker line here. So which would be better out of these? The 0.03 mm molybdenum or 0.025 mm rhodium? Looking at the picture, what do you feel? Anyone? The dotted line is better or the dark line is better? Yeah, rhodium is better. You can see the lower energies and higher energies are more cut off with the rhodium one. And the desired energy, the photons in the desired energy, the difference in rhodium and molybdenum is not very significant. We are having sufficiently high intensity of the 17 kV photons, while more than 20 and less than 15 are more effectively cut off for the rhodium. So this is another with 30 kV X-ray spectrum with rhodium target. So here also you can see the unfiltered and 0.03 molybdenum and 0.025 rhodium. Here you can see that the peak intensity is at a higher level. It is around 20 kV. So previously here it was around 17 kV. Here it is around 20 kV. And we can see that the higher intensity low energy photons are reduced very nicely. 5 to 10 are effectively completely cut off. 25 to 30 are also effectively cut off. And the intensity in this region 20 to 25 and 10 to 15 are also brought down significantly using the filters, both the filters. So here also you can see that the molybdenum, the filtered spectrum is the dotted line and the rhodium filtered spectrum is the dark line here. So here you can see around 20 kV we have a useful energy spectrum with sufficient intensity with rhodium, where it is the if we want to have a high resolution image, we will have to go for the rhodium combination over here. So again, relative spectrum of molybdenum and rhodium for 30 kV 0.025 rhodium filter. So 30 kVp with 0.25. This is the combination of molybdenum and rhodium with 0.025 rhodium filter. So here the difference between two targets are shown with respect to molybdenum target and with respect to rhodium target. So here you can see molybdenum target is giving us a lower energy, high intensity X-ray photons at a lower energy, which is falling in the desired energy range, say 17 kV here, and the rhodium target is giving us a higher intensity beam above 20 kV. So out of this we can see that we will want something which is lesser maximum intensity, lesser energy but with good intensity. And higher energies of characteristic radiation are generated by the rhodium target. So this is again how we will select what this is depending on what is the requirement we need to have. Depending on that, either of the targets are chosen. So the factors affecting the X-ray spectrum, the anode effects, the filter effects, and the applied KV also affects. So here you can see the different combinations: molybdenum, 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 rhodium, 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 and tungsten aluminum we are not utilizing for the mammography purpose. And the applied KV shall be between 24 to 30 kV. So this is another pictorial representation by scrolls where moly spectrum, molybdenum anode, characteristic radiation that you can see here, the 17.6 kV and 19.7 kV, and the molybdenum filter is utilized. So molybdenum filter will cut off energies more than 20 kV. So this area will be completely cut off by using the filter, molybdenum filter. So we will have this spectrum over here, where we have a very high intensity 17.6 kV photon beams are there, and much lower intensity that is 19.7 kV photons with lesser intensity compared to the 17.6 kV. So this energy range it is here is less. It's like 17.6 exactly. It is like 19.7 exactly. And we have the whole spectrum like that. These are the two characteristic X-rays. And energies beyond 20 kV are cut off. So here the molybdenum rhodium spectrum. So the rhodium filter, the K edge correspondingly it cut off 23.22 kV and above. So here you can see it cut off from 23.22 and above. So the primary spectrum remains same as the target is the same. So here rhodium spectrum. So the characteristic energies are 20.3 and 22.7, and the rhodium filter will cut off beyond 23.22 keV. So this is the effective area under the curve for the spectrum of rhodium combination. So here we can visually see that the same patient breast image under 30 kV energizing voltage for different targets. So with respect to tungsten and with respect to molybdenum. So we have more information on the image using the molybdenum target because the energy is lower compared to the tungsten target. So the differential attenuation will be more pronounced in the same density areas or similar density areas. And coming to the advantages and disadvantages of molybdenum target, advantages: increased number of low energy photons are produced, and high radiographic contrast is achieved in the image, produces specific energies required for breast imaging. Disadvantages: less X-ray photon output due to lower atomic number, and increased MAS required to maintain film density, and increased dose to the patient. So this is a graph between the dose, photon energy and contrast. So you can see that photon energy increases, the dose falls down, the contrast also is less, and at the useful energy range for mammography, we can see that we have good dose, the dose is high, and but the contrast is good over here, and beyond and before are less. So optimum photon energy, so here you can see it is somewhere beyond 20 kV. So if the as the components or the photon beams less than this energy will give rise to higher radiation dose to the patient, and as the photons with more energy is part of the spectrum, then we will have decreased contrast. So this is a weighing between dose and contrast of the image. And it can be different for thin breast and thick or dense breast. You can see that here again, the thick or dense breast need a higher kV, and the thin breast will require a lower kV photon energies. So the contrast will be better. Whenever the contrast is better, you can see that the dose is also higher, but correspondingly, it is correspondingly higher. So as it varies, it changes. The dose also less here. So this is a pictorial representation of how a patient is positioned on a mammographic machine. The soft tissue is compressed between the compressing plate and the photographic film. So these are the parts, the anode and the filter. So the focal spot is small focal spot is utilized 0.1 to 0.3 mm, and we have a compression paddle which compresses the soft tissue, and below which the grids are there, so which will cut off the scatter radiation, and we have a film screen receptor on which the image will be formed. So here are the components of mammography equipment. So it is also similar to an X-ray machine. The X-ray tube housing is there, X-ray tube is there, anode is there, beryllium window is there, then the filters are there, and extension cone is there, which helps in positioning correctly so that the patient dose could be managed more effectively. And the compression paddle, this is there so that the soft tissue with different thicknesses could be compressed so that the thickness can be uniform across the soft tissue to be imaged. And we have the grid, cassette, and variable position automatic exposure controller. And the mammography tube is oriented such a way that cathode is at chest side and anode is at the nipple side. What is this? Why is it so? Which is the principle which we are utilizing here?
Line, line focus principle. Line focus.
Heel effect. Heel effect, yeah. And this orientation takes the advantage of heel effect to make the transmission through thicker and thinner part of the breast uniform. Attenuation and sharpness is reduced by this, and equipment bulk near the patient's head is also reduced, and this facilitates easier patient positioning. So here you can see the difference in the beam here to here. If the central beam is positioned at the center of the image receptor, because of the short SID used in mammography, the field size will not be sufficient to cover posterior superior breast tissue. Also, this part will be missing. This is the posterior superior breast tissue. Also, since, a minute, hold on. Also, since effective focal spot size is broader at cathode side, the resolution at chest wall side, where mostly lesions are observed, will be inferior. So here you can see another vertical CR with respect to the reference axis. So in this orientation, we are not missing any tissue. So if the tube is shifted to cathode side such that the vertical central ray is directly over chest wall, under this arrangement, breast is fully covered in the X-ray beam. Also, cathode side of the X-ray beam is avoided so that effective focal spot size and hence resolution remains almost uniform. So, and we can again utilize tube tilt for our advantage to yield smaller effective focal spot size, and double focus tubes are also used in mammography. Focal spot size ranges from 0.6, 0.3, 0.5, 0.2, 0.4, 0.1 mm combinations. Imaging microcalcifications require very small focal spots, and mammography employs the smallest focal spot in radiography. A special anode positioning employed in some mammography tubes where biangular target is used. Here you can see the lower target angle like 0 degree, tilt is about 22.5 degree. So effective target angle is 22.5 degree and reference axis angle is 12 degree. So here you can see the effective target angle is 13.5 degree and the reference angle is 7.5. Instead of the face, edge of anode is bombarded with electrons, and steeper anode angles provide small effective focal spot. And compression device. This is one of the important features of mammographic equipment. All mammography machines contain a compression device that is used for compressing the breast tissue. Advantages: reduced magnification, so reduces geometric unsharpness and increases resolution. Reduced tissue thickness requires lesser KVP, reduction in scatter, increased contrast, and reduced radiation exposure, lesser exposure time for thin body part and lesser entered skin dose, and reduced motion and sharpness, since there will not be any intra-imaging motion because the soft tissue is fixed. And improved visualization, spreading out of tissue structures and less superimposition of overlying structures, and more uniform film density is also achieved by compressing the soft tissue in the field of view. So effect of compression on breast image, spot compression on half of the breast, the single arrow which is shown here, shows excellent contrast and resolution. So you can see that the contrast between these two areas are good and the resolution is also much better. We can identify the high intensity and low intensity, medium intensity areas much clearly over here. Non-compressed side, so this part here you can see that the decreased density due to thicker breast. And if compression is not used, increased technical factors have to be used for obtaining appropriate film density, which would increase the patient dose. And magnification. Magnified projections of the breast are required when the visibility of details in very small structures and microcalcifications needs to be enhanced. Magnification reduces resolution in the image. To regain the lost resolution, a very small focal spot is utilized. This is the smallest focal spot employed anywhere in radiology. And magnifications improve the image contrast by reduced quantum motile, more X-ray photons per unit volume of the tissue. So that will reduce the quantum motile, the motile appearance on the X-ray film, and reduce scatter due to air gap. So here you can see for different SSDs. So images of a plexiglass breast phantom with calcification insert. So the A is the magnified image, B is the non-magnified image. So you can see the characteristics are varying accordingly. So the magnifications of the order of 1.5 or 1.8 and as high as 2 are employed in mammography. So here we have a smaller image, but it is magnified over here. So it is easily visualized, but then some characteristics will be lost. That lost resolution could be achieved by or re-achieved by reducing the focal spot size. Anti-scatter grid is not required in magnification technique because air gap reduces the scatter component. Patient dose is more in magnification because tissue is more close to the source where radiation intensity is greater. Small focal spot necessitates reduction of MA. So 100 MA to 25 MA due to tube loading. Hence exposure time increases. 2 to 4 seconds is the usual exposure time. This necessitates extreme care to avoid movement and sharpness. Use of anti-scatter grid between breast and image receptor for reducing the scatter component. And mammography grids are parallel types having grid ratio 4:1 to 5:1 and grid frequency 30 to 50 line per centimeter. Interspacing of grid is done using carbon fiber instead of aluminium in order to keep the bulky factor as low as possible. Moving grids are used as grid shadows may interfere with image quality. The film screen system in mammography, they are the single screen and single emulsion film. Commonly used screen phosphorus, gadolinium oxysulfate, and slow screen reduced noise and increased resolution. And slow film provides highest contrast and high resolution, about 20 line pair per mm. And film used is green sensitive to match the sensitivity of the screen, gadolinium oxysulfate. The mammography cassette is loaded such a way that the screen is behind the film and the film emulsion is in touch with the screen. This arrangement reduces the light diffusion and improves the image sharpness. Single screen or single emulsion combination also avoids crossover exposure and parallax unsharpness. And automatic exposure control is one of the main features in controlling the exposure so that the radiation dose contribution to the patient could be adjusted or optimized. So AECs or photo timers in mammography are located underneath the image receptor. There are three types of AECs: transmission ionization chamber, photomultiplier tube, and solid state diodes. AECs ensure that the image receptor has received the optimum radiation dose and at that point terminates the exposure and avoids unnecessary patient dose. So once we get a good quality image or the exposure is sufficient for the image formation, then further exposure will be stopped. AECs also determines the quality of radiation by measuring radiation transmission through thicker and thinner part of breast and correct for beam quality changes. AECs are mandatory requirement for mammography machines in many countries. And nowadays we are also in the process of bringing this AEC. We have not made it mandatory in country. You know that we have lot of disparities from place to place, state to state, district to district. So making it mandatory in one go may not be a feasible option. But all the new machines are advised to have the option of AEC so that the exposure could be controlled and the dose to the patient could be minimized. Not only in mammography but also in the general X-ray machines, fluoroscopy machines, CTs, everywhere. And patient dose index in mammography. The middle breast dose was the dose index used until 1970s and it is defined as the dose delivered to the plane of the tissue in the middle of breast. The middle breast dose does not account for variation in breast tissue composition. The glandular tissue is mostly the site of carcinogenesis, hence the preferred dose index in mammography is average glandular dose. And average glandular dose is defined by this equation where XESC is entrance skin exposure in Röntgen measured with an ionizing chamber. VGN is the entrance skin exposure or entrance surface exposure to averaged glandular dose conversion factor with unit of milligray per Röntgen or millirad per Röntgen. The middle breast dose is typically lower than average glandular dose. So the composition of the breast also plays a role in the dose received by the overall tissue. So when that is not accounted for, that underestimates the dose estimation. That was one of the drawback of the middle breast dose estimation. So now we have the average glandular dose, which is more accurate and measured little bit more. Now we have different other modalities also. Not all patients are supposed to be undergoing mammography. Younger patients, mammography may not be a useful tool in identifying the lesions as the breast is more of glandular tissue in the younger people. So as the age increases, more of fat will be there and we can differentiate between the tissues and the mammography is more useful over there. And now we have thermal imaging systems where we can get the similar quality images. Something looks like a Doppler image, color Doppler image with respect to the temperature inside the tissue. So that will give a very good resolution, good quality, sensitive imaging of the breast. So, so there then we don't need to use any ionizing radiation. So we do not have any concerns about radiation hazards over there. Okay, that completes the class today. And did you get the PET slides?
No,
Kancho?
ma'am.
Okay. Okay. Thank you. I'll send both again.
Okay, ma'am. Thank you, ma'am.
Thank you. Yes. Yes. We can use in that is what I was telling. We can use any combination, but what are the optimum? What are our requirements? We have seen the characteristics of both molybdenum target, rhodium target, molybdenum filter, and rhodium target, right? So from that, whatever features are optimum for our purpose of uh, identifying the differentiation in soft tissue, as well as the dose reduction and the optimum energy for at which we need to have the imaging. Depending on that, the selection is done. And you know that the companies are producing it, so they will have to type up patent their combination also. So they will have to make small changes. They will have to market their this thing. So accordingly, small changes will be given, and so some features will be enhanced in some model. Some features will be like that. It is. So we have seen no all the features of all these targets and filter combinations. Yeah. Yes. Some machines are there with tungsten, but they are not advisable. The more suitable ones are molybdenum ones. So now this will, if this thermal imaging, this thing will come into picture, then we might not use the X-ray mammography. And more, and for imaging of the younger patients, again it is not useful. Mammography is not advisable. So we will need to have a CT imaging, mammo CT. So all these things are there. So depending on the requirement, the characteristics which are favoring our requirements are chosen. Yes. Okay. So I thought you are given a schedule for the classes, no? Okay. So today we have completed the mammography. Next class will be okay. Grids are there, but in some specific applications, we are not utilizing that. When we are using the air gap technique, then we don't need to use that because the air gap will reduce the scatter, no? Huh. Okay, okay. Just message me that I will just give you the notes or for all that. Means the answers for all that. What all questions you have. If you are not able to make out from the textbook, then you just send me the questions. I will send you the answers for those questions.
Ma'am,
So
earlier
like
also
it's
components of dual
it's
energy CT also you were telling you will send notes.
I have sent you a Word document with the whole dual energy CT. I have emailed you.
Okay, ma'am.
8 minutes. Let me check. Yeah, check the email on July 30th. So there is a note on Word document for dual energy CT. So which is comprising almost everything.
Okay, ma'am, I'm checking.
Yeah. So along with the ultrasound and CT special applications slides were also sent. So send me the questions. I will send you the answers. That is not a problem. And the slides are just a guide for you to study. You have to read through the textbooks and references. And now reference is not a problem because you have a lot of online resources. IAEA resources are there. They are free. Textbooks as well as the slides are free. So you can go through all that. And if you are not able to make an answer out of it, then send me the questions. I will send you the answers. Podgorsak you can follow. Podgorsak, Christensen. Advancements you can check online also. There are so many things which will come on. See, the most commonly accepted or which are become popular only are survives. No, so many changes comes. Like every scientist is trying to improve the features and reduce the negative characteristics. Every combination has a negative characteristic. We are trying. The scientists are trying to develop something reducing the negative characteristic. In that process, they might get something better, or sometimes the positive characteristic may not be as good as that. So these things will get commercialized, but it might not become popular because the advantages are not that great or things like that. So like this I will send you the note on this thermal breast imaging also, so that that will also help you. And send me the questions, exact what questions you get, so I will give you the answers for that if you are not getting it out of when you read and study. Okay.